Hi everyone, it's a pleasure to be here and to have been invited. I think that I've spoken to quite a few people virtually, so it's nice to meet some people in person. So today I'm going to talk about healing hearts and minds, and this is a kind of combination of a lot of different pieces of work that I'm doing. I'm going to be running through quite a lot of stuff, so apologies if it's kind of a bit overwhelming. And I should also say before I start, I'm going to be talking about trauma and medical trauma, so that might be a bit of a trigger for some people. So I kind of warn you in advance, if you think that is going to be an issue, then you might want to leave. But also if at any point you need to kind of leave the room and take a moment, then please do so as well. It's completely understandable. So today I'm going to cover sort of prevalence and prognosis, which I'm sure we all know quite a lot about. And then a bit of my own story, which might explain my motivation behind all of this work. I'm then going to talk about what trauma is and how increased exposure to this can happen for people living with a heart condition from birth. And then I'm going to talk about my own work, which is trying to promote psychologically informed medicine. And it's something that I'm hugely passionate about. I think there's a lot that we could be doing to improve mental health recovery and to prevent medical trauma for people like ourselves who are living with a lifelong medical condition. And then I'm going to briefly talk about the other kind of side of work that I do, which is to try and more broadly increase changes and awareness of congenital heart disease in terms of policy, practice and social inclusion. So I'm sure most of us are quite familiar with these facts. Congenital heart disease is the most common birth defect, affecting, different papers seem to go between 100 to 125. So 1 in 100 to 125, so approximately about 1% of the population. And this is a medical success, or it's badged as a medical success. So we now know about 90% of babies who are born with a heart condition will now survive into adulthood. But around a quarter of those babies will require medical intervention within the first year of life. So we now have this growing population, we're all here today, of adult survivors. However, there isn't any cure for complex congenital heart disease, and lifelong monitoring is now indicated, with an increased mortality and morbidity burden. So this is one of the pictures from our Scarred for Life project, and it's nice to see the posters out there again. So in terms of my motivation for this work and my own story, so when I was 11 days old, I was fitted with my first pacemaker. I was the youngest baby in the world at that time. It was back in 1978, and this was at York Hill Hospital in Glasgow. And I've been completely 100% dependent on a pacemaker since. So it's been a bit of a tenuous journey. Because it was pioneering treatment at the time, I was in and out of hospital all the time. And I can remember a physicist had to come in from Glasgow University to teach the doctors how to work the pacemaker kind of on me. So I can just remember spending hours kind of lying in a hospital bed with a team of guys with white coats, kind of put my heart rate up and down with this big magnet. The prognosis at that point was uncertain. My parents were told they'd be lucky if I lived till I was 12 years old. And by the age of 7, I'd already had 5 pacemakers by thoracotomy, so pretty big surgery. When I was 12, they found an ASD, so I required open heart surgery to fix that. So around about the age of 12 to 14, I can remember I had to have a thoracotomy to kind of fix the pacemaker. I got a new pacemaker up here, then they found a hole in my heart, so they had to do open heart surgery. So it just seemed relentless, at quite a pivotal stage of development. And I've always lived as normal a life as possible, but felt a lack of wider understanding and psychological support. Back in those days, there was absolutely no psychological support, and I'm sure that's been the experience for many of us. And when I was about 15, around about that age, it's kind of hard to remember, I developed what were deemed as medically unexplained symptoms, which were mainly kind of chronic fatigue, generally not feeling very well. And they were labelled with different things, pacemaker syndrome, and then eventually PTSD, or chronic fatigue syndrome, and nobody was quite sure what was going on. And with the PTSD at that stage, this is by now, it was kind of the 90s, I was offered 2 sessions of EMDR. I don't know if you've heard of that, but it's basically the eye movement desensitization. So I was out with the context of seeing any psychologist. It was just 2 sessions of this, and this was meant to kind of fix it. As you can imagine, it wasn't hugely beneficial, it didn't make much of a difference, and I just learned to live with the symptoms of chronic fatigue, flashbacks, nightmares. I had quite a lot of nightmares about kind of being in hospital, dying in hospital, quite early stuff. By the time I got to my early 30s, because of my own training as a counselling psychologist, you're required to have mandatory therapy. And when I had mandatory therapy, that in itself kind of raised other things. It almost kind of took the lid off things. And I was recommended to go for body psychotherapy, which I found incredibly helpful and life-changing. And at that point, I got a kind of true understanding. And it was the first time somebody had listened to me and actually validated that your experience in life isn't normal. Normal people don't go through the things that you've gone through. And that in itself was really empowering for me. So we all have different stories. All of us have had different interventions. We all have different conditions. We've all had different social support around us. But I think that understanding our story helps us to make sense of it and empowers us. And things have moved on massively since I was a child. Understanding in psychology of trauma has improved enormously over the last 40 years. And I've got no doubt that my own experiences have driven my career in psychology. Yet the psychological impact of congenital heart disease is still widely neglected, and I'm sure many of us have experienced this, and support remains poor, unfortunately. So the babies who missed out when we were children because we didn't really know enough are now missing out again as adults in terms of psychological support. And I think that it's important for kind of the medical profession to understand and take responsibility for the fact that while they have gifted life, medical successes raise new challenges, and we need to shift from a survival focus to a holistic understanding of what it genuinely means to live with a lifelong medical condition that requires intervention. And we need to embed better understanding in care provision to improve outcomes and mitigate against adversity, to build on resilience and prevent, and also post-traumatic growth. So I really like this quote from Angie Masters, which says that I think one of the most important things that I would change would be an acknowledgement from the medical profession that what we're doing to these tiny babies will affect them for the rest of their lives. So what is trauma? A lot of people talk about trauma. What is it? So in terms of official diagnosis, there are two different types of trauma. So there can be a sudden event, like a road traffic accident or an attack. That's called a type 1 simple trauma. Then there's type 2 trauma or complex trauma, and that's when there is repeated, often interpersonal events from childhood that go on, and there's more than one incident. And they can be chronic and cumulative over time. There's also quite a lot of talk at the moment, particularly in Scotland. The Scottish Government is driving this awareness of adverse childhood events. And there's increasing recognition that adversity in childhood is associated with increased risk of poorer mental and physical health, and a range of poorer psychosocial outcomes. So in terms of trauma, what are trauma-related disorders? So in terms of type 1 trauma, which is usually what happens when there's maybe like a one-off incident, like a road traffic accident, then it's associated with what we call post-traumatic stress disorder. And post-traumatic stress disorder results in sort of hypervigilance, symptoms like having difficulty sleeping and concentrating, low mood, self-blame, often reliving of the traumatic event, so nightmares, flashbacks, and avoidance as well, so avoidance of going back to where whatever the traumatic event was happened. Type 2 trauma, or complex post-traumatic stress disorder, as it's known in DSM-5, is slightly different. So this is more kind of if you've had kind of chronic cumulative events, and it's associated with a sort of pervasive sense of shame and guilt, difficulty controlling emotions, dissociation, so kind of feeling numb and not kind of connecting with what's going on, physical symptoms, relationship difficulties, risky behaviours and suicidal thoughts. So these are the kind of diagnosis if you want to give it a diagnosis. Another way of understanding trauma I kind of prefer is that if we're subjected to trauma, then our nervous system becomes biased to cues of danger. So if we've had a perilous history, then we're kind of more likely to be expecting bad things to happen again, and our nervous system is kind of more attuned to danger. So this graph kind of shows the middle bit is kind of where we would be if everything's fine, we feel calm and we feel relaxed. If a tiger walks into the room just now, we would expect us to go into the kind of upper bit of this graph, which is our fight or flight response. And that's a normal physiological reaction to a threat. So you would kind of feel anxious, panicky, your body goes into a mode where it wants to do something, it wants to fight or flee the situation. However, if the situation that we come across, we can't fight or flee, and it's actually more dangerous, then what our bodies do is they actually go into a sort of death feigning mode, and they play dead. So that's the bottom part, and then our nervous systems kind of shut down. Our heart rates go down, we become low, and we have chronic fatigue, disorientation, sense of kind of numbness, because our bodies actually physiologically are playing dead, or playing possum. And what you can find is that people who have a lot of trauma kind of flip between the top and the bottom. So they can be quite kind of anxious, nervous, kind of looking for danger, and then they can flip to the bottom bit where they're actually quite disconnected, withdrawn and depressed, and they can kind of flip between these. So trauma-related disorders are characterised between kind of going between that anxiety state and then also feeling numb and disconnected. So in terms of post-traumatic stress disorder with congenital heart disease, what does the research tell us? So kind of studies that have been done have shown that 12 to 31% of children who undergo cardiac surgery develop post-traumatic stress disorder. That's a huge proportion. And 21% of adults with congenital heart disease have post-traumatic stress disorder. That's versus 3.5% in the general population. 34% of that is related to cardiac surgery and 41% related to other cardiovascular events, such as arrhythmias, heart failure, stroke. This is also an issue for parents. So nearly 15% of mothers and nearly 10% of fathers who have children undergoing congenital heart disease surgery experience post-traumatic stress disorder 6 months post-op. So these figures are huge. And this currently is not being addressed. There is no screening going on in our clinics, and services aren't there to meet this need. And when we think about this, if you've got a child who's traumatised, who then has parents that are traumatised, this is a really disturbing picture. So what I've started to think about is why. Why is this happening? Why is this picture there? So we know from the literature that not everybody develops PTSD after a traumatic event. Okay, we all have traumatic events throughout life. It can be a normal part of life. Life isn't smooth for anybody. And there are certain factors that can make PTSD more likely. So things that increase the risk of developing kind of trauma disorders are your mental health history. So if your mental health isn't great already. Feeling powerless and objectified are huge contributing factors. So if you feel like you couldn't do anything in that situation, if you had no power over it, or if you were objectified, and passive acceptance, so I can't do anything about this, I've just got to take it. Additional life stressors, a lack of social support. So just bearing in mind there that we're talking about the parents are maybe also traumatised, so maybe not able to offer that social support. It depends also on the exposure and severity of the traumatic event, so how long did it go on for, how severe it was, but also what it means to you. So a big part of it is what it meant to you. So did you believe that your life was at risk? Did you believe that there was nothing you could do about it? And peri-trauma dissociation, so did you go into a dissociative state at the time? Was it so overwhelming that you kind of dissociated? And previous exposure to trauma, so if there have been, so again, it can be kind of cumulative. So thinking about these factors and thinking about congenital heart disease, we've almost got the perfect storm of risk factors. So we know that mental health history within the congenital heart disease population, there are higher risks of both depression and anxiety. So depression is 31% versus 11% in the normal population, or non-congenital population. And anxiety tends to be about 28% versus 17%. There's also a higher prevalence of neurocognitive issues as well. Add to that a sense of powerlessness. So there's disempowering aspects of care. If we think about how medical care is provided, so things like being put in the patient gown, being in the patient role itself, clinical holding, feeling objectified, and I'm going to go into these in a little bit more detail. The fact we also can feel powerless because there's poor care provision. Services aren't meeting what we need. So, we can have a sense of where do I go if something goes wrong? How can I manage my own condition? So that sense of not feeling safe. Higher risk of life stressors, So I'm going to go into these in a little bit more detail. Heart and mind link, inadequate social support, and then repeated exposure. So all of these factors are there and can contribute to that. And obviously each of them varies, for each of us. So in terms of a sense of powerlessness, one issue can be clinical or forceful holding. So Lucy Bray's been doing some really interesting work. She's a nurse, and she's been looking at clinical forceful holding within the kind of nursing profession and looking at health professionals. And they conducted a study where they found that 81% of health professionals report that children are being forcefully held for procedures frequently or very often. And this is despite the fact that professional guidelines say that it should be a last resort. In terms of a sense of powerlessness, actually being physically held for something that's painful is quite worrying. And often it's the parents that are asked to do the holding. So, and parents have their own feelings about that, mixed feelings. So it's kind of impacting on parents' mental health as well. There are also many other disempowering aspects of care. So authoritarian communication styles within hospitals, hospital gowns, lack of privacy, lack of knowledge sharing, kind of invalidation of symptoms, being in the patient role, so lots of different aspects of care that can contribute to that sense of powerlessness. It's a slightly overwhelming slide, but it's also well established that if you're born with a heart condition, there are a number of different life stressors that you might also face, out with just the medical condition. So you might be missing schooling, having to constantly catch up, a lot of uncertainty, surgeries, living with an implantable device, physical limitations, missing out, comorbidity, discrimination, which can be quite nuanced but present. So yeah, quite a few of them. And this is kind of tying into a little bit more of my own work. So yeah, I've been quite interested in something called polyvagal theory, which is basically a theory by Professor Stephen Porges about how we have evolved to constantly look for threat, and how our bodies, our nervous systems look for threat and how they deal with that. And he calls that constant act of kind of assessing how safe we are, he calls this neuroception. And kind of tying into the slide I had before, that kind of graph, he says our bodies have three different systems. So if we are feeling safe, and this kind of ties in with our body's physiology, but basically if we're feeling safe and we think everything's fine, he says we're in our social engagement system. And psychologically we feel calm, we feel relaxed, we feel connected to other people. As soon as we feel threatened, we kind of go into fight or flight mode, and we're kind of expecting there to be danger, there's risk, and psychologically we feel anxious, we feel nervous, and our bodies do that on purpose because we're having to respond to threat. And then again, kind of if we feel like we might actually die, we go into that kind of playing dead system as well. And I've been working with Stephen Porges, and I contacted him to say, well, since the heart is a central part of the nervous system, if our hearts are maybe not quite as kind of homeostatically connected to our nervous systems because they're maybe a wee bit delayed or there's a pacemaker or whatever, would that mean that our kind of ability to respond to threat might be a little bit different? And he was interested in this idea, and he felt that yes, it could be. So there might actually be a physiological reason as well, a kind of biological reason as to why we're more likely to feel anxious. So this is kind of a chapter that I wrote for a book that he had out last year. And if you think about the risk factors, another one was that we need to have good social support. However, often our social support has been compromised from the start. So in terms of safe connection, it's really important when we're growing up to have a safe connection to our parents as babies. And we learn from that kind of biological dance with our parents about how to regulate our emotions. And it also creates what we call an internal working model of what relationships are like, that our needs will be met by another. And that's how we develop normally. But kind of looking at the second picture here, if we think about the physical barriers to that attachment, but also thinking about the mental health of the parent as well. If we look at the kind of trauma figures and how maybe mum or dad are feeling, then there are significant barriers to forming that early attachment. And that social support can also be compromised, particularly for kind of the older generation of us, because kind of back in the even up to the 80s, it wasn't encouraged that parents would be in hospital. So almost when you needed your parents most, it might be that they weren't there or weren't encouraged to be there. So yeah, that can impact as well. And then when we think about the kind of the trauma risk factors, there's something about repeated exposure. And of course, there is repeated exposure with CHD. So from infancy and across the lifespan, we might have to undergo frequent procedures, hospitalisations, and those medical procedures can be painful, they can be stressful, they can give a sense of life threat. And then there's also cardiovascular events, so it's not always like the medical events themselves. So arrhythmias can be really scary, having that sense of arrhythmias, heart failure, stroke, cardiac arrest, and we know that they can also contribute to trauma. So I know this all seems like a bit of a bleak picture. So I've had to kind of think of, what can we do about this? How can we make this better? And I've kind of called this psychologically informed medicine, and I think there is lots that we could do to make this picture better. There's so much that we know now within psychology. So yeah, I think that let's work together, let's improve care and use contemporary psychological knowledge to improve mental health and wellbeing, and which will also inevitably improve physical recovery. We can also build on resilience and post-traumatic growth to prevent medical trauma. And I do think this would reduce spending within the NHS, because a lot of the cardiac appointments and consultants are having to deal with, and nurses, is about emotional support, it's about feeling anxious. So I think this is really important. Deb Dana, she's a body psychotherapist in the States, and she works with Professor Porges, and she co-edited the book that I have the chapter in, makes a really interesting point, and she says that many of the systems that are embedded in our communities, such as schools and workplaces, and I would add hospitals to this, have been developed without any regard for the role of the autonomic nervous system in guiding. So systems have been developed without thinking about the psychological needs that we have, and how they could be informed to make us feel safer and to prevent trauma. So one of the really important things in terms of feeling safe, what I mean by the safer that we feel, the less likely we are to become traumatised. Okay, so if we can make people feel safer and more empowered, then they're less likely to become traumatised. And one of the most protective factors and things that make us feel safer is having a loved one with us and having that connection. So really promoting that from the start, having parents or loved ones in there at the baby's side. Touch is really important. So we know that touch facilitates the vagus system, which basically is our kind of biological system, that makes us feel calm. So touch expresses compassion. It makes us, and it gives feelings of reward, reciprocity, and most importantly, safety. And studies have shown that preterm infants will significantly gain more weight when they're touched. So the evidence is there. And that compassion is also expressed through vocalization. So just having, mum or dad or whoever the caregiver is there, being able to touch the baby and sing, it means the babies are more likely to recover. They put on more weight. We know this. Okay. I think we should develop hospitals to be more healing environments. So they're very clinical. That's how they've been developed. They've been developed in terms of kind of hygiene and with that in mind. And obviously all of that is incredibly important. However, back to Deb's quote, I think that they haven't been developed bearing in mind the psychological and emotional needs of humans when we're at our most vulnerable. So things like good communication and compassion, I think, should absolutely be fundamental ingredients in medical training. I mean, it might be your experience, it's certainly been my experience that when somebody says the wrong thing to you when you're at your most vulnerable, you play it over and over in your mind, even many years later. It's just not okay to do that. And the thing is that a lot of, we can't just rely on bedside manner being good, casually. Some people have got it, some people haven't. It needs to be a core ingredient of training. And I think we're at the point now where we realise that actually survival rates increase when doctors make eye contact, when they provide reassuring touch, and when they have reflective practice. And I think that we need to bear in mind the mental health of our doctors. They're doing really hard work, and nurses. So in terms of protecting them, perhaps if they had supervision, if they had a space to discuss how things challenged them, then they would be in a better place to contain our emotional responses as well. I think we need to rethink unnecessary disruptions so basically these came from, I spent it felt like a year, a month in hospital last year waiting on a new pacemaker. And it was quite a good field kind of trip, because I made note of all of the things that were not making me feel safe. And they were things like being woken up at a ridiculous clock, I think it was at 5 o'clock every morning to have my obs taken. So it's just like, why? What am I going to do for the next 3 hours? And there was absolutely no need for it, but it just fitted with a shift change for nurses. The lighting was really harsh. People came in and out my room constantly. There was no privacy. I had this kind of silent, passive-aggressive war with I don't know who it was actually, but I kept closing the door to my cubicle, and they kept opening it, and I kept closing it, and they kept opening it. I don't know why. So there's so many things that just, on a basic human level, are just unnecessary. Addressing systematically depersonalising aspects of care, so things like hospital gowns, and I'll go into that in a bit, lack of privacy, not telling us stuff. Hopefully things aren't as bad as they were now, but I can remember as a child them standing, the kind of team standing, talking about me in the third person at the bottom of my bed, and I could hear them, but it was just so objectifying and disempowering. Challenging practices such as, so I think things like bravery stickers, yes, it can be nice to get a reward, but if bravery stickers are used to reinforce emotional suppression from an early age, that's pretty worrying and can be quite damaging. So it's kind of trying to get that balance right. And things like forceful holding, that really needs to be tackled. And Lucy Bray did a follow-up article which was for clinicians in terms of what alternatives are there to that, which was really useful. Consistency of care, so to feel safe, we need to have a good relationship with our care providers. If that keeps chopping and changing, or we don't know where to go, it makes you feel really unsafe and really high risk for kind of feeling traumatised, quite understandably. And adequate pain relief as well. Okay. When we do require psychological support, which may be inevitable, and I don't think, why is it not liking that one? And I think that's absolutely fine. I don't think there should be any stigma around that. We're facing so many unusual life events, things that most people don't have to face in life, and having a safe space to talk about that and explore that is absolutely fine. And I think the psychological treatment in itself needs to be trauma informed. So when we're kind of feeling traumatised, sometimes like kind of more sort of CBT type therapies, cognitive behavioural therapies, really mean that we have to kind of be engaged in a kind of headspace. Whereas with trauma, it's often very embodied, and there are a lot of kind of physical symptoms. So often it's about safety and stabilisation first before you can go into processing events. So having a kind of therapist that is trauma informed and using kind of more body-based ways to manage that increased arousal, so mindfulness, breathing exercises, meditation. And we also know that overcoming adversity is associated with post-traumatic growth. So it's not all bad news. People who have been through significant adversity often have greater empathy, a deeper appreciation of life, and personal strength, and closer relationships. So we can build on this post-traumatic growth as well to empower people. And we know there's not just adverse childhood experiences, there's growing evidence for protective childhood experiences, so particular experiences that protect us as well. And these are things like strong family support, having good friendships, a sense of belonging at school and in the wider community, and feeling safe at home. So when we're looking at kind of youngsters, trying to make sure that these protective experiences are there as well. And I think that's one of the wonderful things the Somerville Foundation offers, many of these things, that sense of belonging, that sense of having a peer group that you maybe haven't had. So this is just a little bit about my own research that I'm doing just now. So one of the things I've been looking at in particular is the impact of the hospital gown. And it's grown arms and legs. So this came from my own sort of experience of kind of lifelong been put in this gown, and always kind of wondering, is this absolutely necessary? I already feel like I have no control over anything, things are bad enough, and now you're asking me to wear this gown with kind of basically my bare bum hanging out the back. Could it possibly get any worse than this? The last time that I was in hospital, I can remember just before surgery, I was sitting in this gown and they were like, oh, we forgot to take your weight. So the hospital I was in was incredibly busy. It was like, there was people everywhere, and they're like, you're going to have to walk across to get weighed. So I had to walk across in this gown to get weighed. So I'm like clutching it at the back, just no underwear on underneath, just thinking, could this get any worse? So I started to think, why do we need to wear this gown? Is there any research on this? And actually there was a dearth of research. Not many people have looked at that, and I don't know if that's because it's a patient thing, and things that tend to be studied tend to be more from people who are empowered, but yeah, it seemed to be kind of unclear in the literature. So there was one study, and it was a Canadian study, and it showed, and it was actually done by doctors in an acute care setting, and what they found was that 89% of people in acute care were being put in a hospital gown, but it wasn't actually medically necessary for more than half of them. Okay. And there were a couple of studies, and they had shown that wearing a hospital gown was associated with, it wasn't just the hospital gown, it was hospital clothing. So they had found that some people found that they felt more comfortable and cared for, but predominantly people felt depersonalised, stigmatised, devitalised, that they didn't have control and privacy and limited mobility. However, the two studies that had been done they'd covered like pyjamas, dressing gowns. It wasn't just the hospital gown. And they'd also looked at carers as well. So we decided to have a look at this, and we did two different studies. So we did an in-depth, semi-structured interviews with congenital heart patients, and thanks to the Somerville Foundation, we did this in collaboration with them, and we recruited some people. And then we did a kind of wider cross-sectional study, because what we quickly realised was that actually this was a bigger issue than just congenital heart. So we interviewed 10 people with congenital heart disease, and what we had found was, I'll just run through this quite quickly, but there was sort of 4 themes. So wearing the hospital gown was associated with a loss of healthy identity. So people were saying things, like, as soon as you put it on, you feel like a piece of flesh, you're not a person anymore. It was also associated with going into the sick row. So it was like, as soon as you put it on, you became sick. So one of our people had said that he was going in for a pacemaker change. He didn't actually feel that ill. It was just that the pacemaker was kind of near the end of life. But as soon as he put the gown on, he actually felt ill. It made him feel kind of sick. It's also associated highly with vulnerability, feeling disempowered and embarrassed. So there's a lot of kind of feeling embarrassed with it. So Rebecca had said it's almost prison-like. These are pseudonyms. And then, so Callum, he had said when you walk around or so, it can be open at the back. So you're quite often trying to turn your back and cover it up. So there was this real sense of people actually not doing much as well. They were just kind of sitting still because they felt if they got up or anything, they would be revealed. And then this sense of actually handing over control to medical professionals. So suddenly you feel like you're hospitalised, so some quite good quotes there as well. What we did after that was our broader online survey. So 928 people completed the online survey, and this was for anybody, not just congenital heart patients. Most of the people that responded were female, and interestingly 45% of the people that responded identified as having a long-term condition. So 60% of those people that responded said they weren't actually sure that they really needed to be wearing it, which is quite kind of concerning. And mostly they identified as feeling exposed, self-conscious, vulnerable and uncomfortable. And cold came up quite a lot as well. And if you think of people who are not well, to then be feeling cold on top of that, it's not great. 64% struggled to put the gown on themselves. And then nearly 60% said that it possibly kind of limited their mobility and their movement. Most people said it didn't fit. And interestingly, it's like kind of nurses have come up with their own solution. So 41% of people had been given a second gown to wear the other way around, which if you think about in terms of waste in the NHS, But also, if it's about accessibility, if almost half of people are now wearing one knotted this way and one knotted that way, then how is that accessible in any way, shape or form? And interestingly, around about 75% of people said that they felt it affected how they felt about themselves, but also how others perceived them. And if you think about this in terms of trauma and all the risk factors for trauma, just adding to that sense of vulnerability and feeling objectified. So we came up with some recommendations for a kind of different looking gown, and you can kind of look at that. We also wrote an article for The Conversation. So The Conversation, I don't know if you've heard of that, but basically it disseminates kind of scientific studies, but just to the general public. So I've done a couple of articles for them just to try and increase awareness about kind of mental health problems and needs, but also we did one on the hospital gown. And the one in the hospital gown, we've been together, there's been over 40,000 reads, but the one in the hospital gown really provoked quite a lot of online chat, which was great. And it was republished in The Independent, it kind of went viral, it was featured in the Glasgow Evening Times, and we were really excited to win. So I had submitted, this was a picture I took of myself in a hospital gown when I was in the hospital last summer. It was a selfie. I don't know why I took it at the time, but Strathclyde University has an Images of Research campaign, so you competition, so you can kind of put in images of the research that you're doing. So just because I happened to take this selfie just before I went for surgery, I popped it in and told them about the work that we were doing on psychologically informed medicine and the hospital gown. And amazingly, we won, which was great, because that picture then went into the Glasgow Science Centre, and they kind of do a year-long project. So it's now kind of outside the Glasgow Science Centre on the River Clyde. And it was quite emotional for me to see that, because it's actually straight across from York Hill Hospital, where I had all my paediatric operations. And we've got a little video of the background story there that you can click on to see. Part of this work has been done with Wellbeing, and we've been given them recommendations in terms of their products as well. So you can look at that as well. Just kind of conscious of time. So another piece of work we're doing is basically we're trying to develop a measure of safety. So there is no measure of safety out there. So this is some work I'm doing with Stephen Porges just now. And you can look that up if you want. And just to finish up, one of my main interests as well outside of this is the voluntary work that I do to try and improve care in Scotland. I've had several near misses with my own care, and I find that incredibly frustrating and concerning, given everything that we go through in childhood. I don't really want to kind of drop down dead unnecessarily as an adult. I don't mind if there's no choice in it, but if it's just because somebody's not going to listen to me or I can't access care, then that's really quite worrying. So following that, we submitted a petition to the Scottish Parliament, which you maybe heard about in 2012. And since then, I've been working as Scottish campaign manager for the Somerville Foundation and doing various different bits and bobs. But eventually, in 2018, we got standards for the National Service for National Care, which was amazing after a lot of work. And I'm now sitting on Health Improvement Scotland. They've got a recent kind of group. They've taken on the piece of work looking at national standards for local care, because most of the problems are actually with local care provision. And we also have a Scottish Obstetric Cardiac Network as well, which I'm sitting on, which is great. So yeah, and one of the main things that I do, just to kind of finish, is just trying to raise awareness. So if you think about things in terms of safety and preventing trauma, one of the biggest protective factors is social inclusion, and that's one of the kind of risk factors for us, is that we don't feel socially included. So just trying to raise awareness, trying to get public awareness out there, so kind of trying to do that across the board, trying to do it amongst medics, but also patient groups, but also in my own profession of psychology, and just trying to kind of make this something that's a bit more understood mainstream. Okay, well, I don't know why that came up. So just in conclusion, there's a growing population of people, as we know, like ourselves, who have been living with a heart condition from birth. And we are at increased risk of trauma and mental health problems because of that, because of maybe as a direct result of our condition, but also in the name of the medical treatment that we need and the many additional life stressors that we face. And to date, these psychological issues, they've been completely neglected. But there's now improved psychological understanding, and this offers the development of psychologically informed medical care and strategies to improve our mental health recovery and to prevent trauma-related disorders. And advocacy can help to promote our inclusion and understanding, and this should be embedded in policy and practice to enhance wider inclusion so that we can all reach our full potential. Thank you.